Thank you very much, Dr. Usman, for volunteering to do this one. I know the review in this article from a gentleman who actually is working right now in Ireland, who you have worked in close contact with him, is going to add a lot of insight on the way that this article was written. Just because we started late, I'm not going to waste a lot of time and everything, but we all familiar with Dr. Usman. He's one of our wonderful associates who works with us in Owen Sound. Dr. Usman, you can please lead.
Yeah, great. Thank you, Dr. Hassan and Fatiba, for organizing. And thank you everyone for joining in. So the title of my presentation is Flap Design in Oral Surgery. So some of the topics we're going to discuss today. We'll start off with an introduction. We'll look at some surgical considerations. We'll look at the principles of flap design, some instruments, common types of flaps, and flaps designed for third molars and dental implants, and then finally flap closure. So many oral surgery procedures require the lifting of a surgical flap to gain access to the surgical site. Flaps are necessary to facilitate surgical tooth removal, treat pathology, and create access for bone and tissue augmentation procedures and the placement of dental implants. The type of flap used affects how easily primary closure can be achieved, how quickly the site heals, and the risk of complications. Poorly designed flaps can break down, become necrotic, and increase the risk of failure. So you can try to take out a tooth conservatively using proximators and special forceps and piezotomes, which expand the bone and sever the PDL and luxate roots. But when your atraumatic techniques are unsuccessful, a surgical flap is indicated. And interesting to note, done correctly, a surgical flap will make the procedure less traumatic than performing without a well-visualized surgical field. So several basic principles of flap design must be followed to prevent the complications of flap surgery, which are flap necrosis, dehiscence, which is separation, and tearing. So a good flap carries its own blood supply, allows surgical access to the underlying structures, can be replaced in the original position, can be held in place with sutures and is expected to heal, has a base wider than the apex, and doesn't cross any bony prominences like the canine eminence, and avoids injury to the mental, lingual, and greater palatine nerves and vessels. So some common instruments that we're all very known to. So just use a clean scalpel and tissue forceps, and then your periosteal elevator to lift your flap, and then continue with your procedure. So the type of flap used in surgery varies based on its purpose, the particular surgery, and the anatomical area of the procedure. So we use a scalpel to incise the sulcus and the interdental papilla on the facial and possibly lingual aspects of the tooth, and then a full thickness mucoperiosteal flap is developed. To avoid tearing the tissues, which might be quite friable as a result of inflammation or infection, it's important that the incision is made down to the bone, and that the incision extends to the far interdental area of the teeth on the mesial and distal. So our first type of flap is the trapezoidal flap. This is a horizontal incision along the gingiva and two oblique vertical releasing incisions extending to the buccal vestibule. These incisions always extend to the interdental papilla and never to the center or the buccal surface of the tooth, just to maintain the integrity of the gingiva and prevent recession. There's just a clinical photo and a diagram. So this one has two releasing incisions. Our next one, the triangular flap, only has one releasing incision, an L-shaped incision where the horizontal incision made along the gingival sulcus, and a vertical or oblique incision. So some studies found that the triangular and modified triangular flaps are associated with more swelling than other flaps. And our third type is the envelope flap, which doesn't have any releasing incisions. And this type of flap is a result of an extended horizontal incision along the cervical lines, but it has a higher incidence of dry socket, but some studies found less post-operative pain. And then some less common types, so the Y-shaped for palatal tori, the semilunar flap for apicectomies, and the pedicle flap to close OACs. For third molars, there's multiple ways to reflect a flap, but most designs have one thing in common: buccal circular incision beginning along the 7, extending over the area of the impacted tooth. And it's very important that you stay away from the lingual aspect of the tooth, as the lingual branch of the trigeminal can be very variable. Just to touch on implants, so on the right side top, you can see the punch flap, and then the bottom left, the half punch, and then the bottom right, the mid-crestal. And then we have our palatal crestal, we have our distal and mesial papilla preservation flaps, and then we have our double papilla preservation flap. And then to close the flap, so the purpose of suturing is to approximate surgical flaps to their original position and to hold them in place long enough for healing to occur. So the selection of suture material depends on the purpose and the duration needing tissue support, as well as the location and accessibility of the surgical site. So for most of our cases, we're going to use silk or gut, and they have varied ranges of sizes, but we'll either use a 4.0 or a 3.0. So our non-resorbable is silk, and it stays in for about a week, and they shouldn't be left in for more than 7 days because there's a risk of infection. And then for our resorbable sutures, we have gut, which is made from sheep intestine. These last about 3 to 5 days. And then if you want it to last longer, use a chromic gut, which lasts up to 10 days. And this diagram just shows the classification of sutures. So you can see our plain gut and our chromic gut, and then our silk on the right side, and then some other less common types. And then to suture properly, it's important to place the needle in the needle holder correctly. So the needle should be at the tip of the needle holder, approximately 2/3 of the way from the tip. And then the paper that you wanted me to discuss is by a colleague in Dublin. So his thesis was a comparative study of the effect of one suture and sutureless techniques on post-operative complications following third molar surgery. So his conclusion was that the one suture technique for lower third molar surgery is superior to the sutureless technique because you had less post-operative pain at day 5 and day 6, and improved wound healing at a week and a month. But he found no difference between the two when you were looking at post-operative swelling. And that concludes today's presentation. So I will start the poll, and we'll give it about 5 minutes or so.
Dr. Usman, do you want them to ask questions before the poll? Do you think that's better? Just in case if they have any questions.
Sure, I don't mind.
Right, wonderful. Guys, do you have any questions at all? Okay, I'm going to start asking you questions in this case. So what are the basic principles when you raise a flap? What are the things that you probably want to consider whenever you raise a flap?
So you want to keep the blood supply. You want a base wider than the apex. You want ideally primary closure. and you want to stay away from your vital structures like your mental framing and then your nerves and blood vessels.
Okay, and the thickness of the flaps, there's different thickness of flaps, right? All about the purpose, as you mentioned. Do you want to elaborate on that?
Yeah, we usually do just a full mucoperiosteal flap. I didn't really look into the other types.
So the whole idea about split thickness is the blood supply. Obviously, you don't want to deprive the area. So whenever you want to have your outer layer or your soft tissues and don't want to impair it, you probably will be doing a split thickness. Whenever you want to transfer a place or a tissue from a place to another place and extend it, you probably want to consider doing a pedicle flap that would have its own blood supply. Okay. Regarding your thing, you've mentioned something. Is there something about keeping the flap moist? Is that something that you think is important? Is the time that you raise a flap does affect as well the outcome of closure at the end with regards to the swelling and the pain?
Yeah, you should ideally try to do your procedure as quick and effectively as possible. So your flap shouldn't be open for long and it should be moist at all times so it doesn't necrose.
So we have in the chat a question/answer from Rosati. I think split thickness flaps are used in periodontal surgery? Question mark.
Absolutely. It's absolutely a right answer.
Yeah, so the first question, the size of the suture used commonly for us in oral surgery, either C or D is correct, but most people pick C. And the second one, which is not a principle of flap design, so they're all correct apart from A. It should be the base wider than the apex. And this third question, they're all types of flaps except D, rectangular, which I made up. Fourth, which of these types of sutures are resorbable? So silk is non-resorbable, and then chromic, gut, and vicryl are all resorbable. So E is the right answer. The fifth question, which of these types of implant flaps require no closure with sutures? And that's the punch flap. And then we have some true or false. So the suture needle should be at the tip of the needle holder, approximately 2/3 of the way from the tip, and that's true. Chromic gut suture is made from sheep intestines, that's true. Chromic gut sutures last about 3 to 5 days. So your plain gut is about 3 to 5 days, and then your chromic gut is about 7 to 10 days. So that one would be false. And then our ninth question, when raising a flap for exposure of third molars, avoid any extension of the incision to the lingual. That's true. And then our last question, the envelope flap is a result of an extended horizontal incision along the cervical lines of the teeth. That's true.
Okay. So while we're doing the polls, Dr. Usman, I believe that we had a question, and I believe it's a very, very good question. So Dr. Kura has asked, what would be the most easier flap? I love the word easier to do for mandibular third molar extraction.
I mean, there's many different types. Like all surgeons have their own way of doing a flap for third molars. The easiest one is the one you've practiced the most, I guess. But I don't think any one type or one variation is easier. I think most people do lift the flap off the 7 completely. But what would be your way?
I mean, when I answer this question, I always like to think about, purpose. And what is the purpose of a flap will be visualization and access. That I want to visualize the area and I want to introduce my instruments to the area, whether they were rotary instruments like a handpieces or things like that, or whether it was elevators, and I personally prefer the lower right flap, probably with you. The only modification to that is that I will be probably way more buckle than what you are right now, because as well, basic principles flap not only to consider up the base to be wider than the apex, and to make sure that you have involved the whole layers of your tissues up to the subperiosteal, but as well, you have to take in consideration other anatomy, like the lingual nerve that we know for a fact from a previous anatomical cadaveric studies that it can, in about 25% of the time, goes above at the area of the retromolar pad and run towards even the distolingual cusp of wisdom tooth. So these type of situations probably will always let me think that why do I need to go crystal? I'll go just buckle, and I'll go buckly, and I'll open a buckle window whenever I do that. Um, I think this is something that I'll gladly, if you all want to speak about in further details. I've got I think at one point in time, a dental school in Poland have asked me to present a lecture to them. And I've actually done that, and I've already got the material. So I will gladly, do this with you if you want on the next visit. But that's up to you if you guys want to, just to strengthen the information that we've retained up from today. But to answer the question, yes. Just a couple of points. I truly wanted you, to, and I didn't mention it to you, but I thought that you will probably do a little bit of a research. But there is a Cochrane study that it was published about surgical techniques and extraction of wisdom teeth, and it had compared up all the types of the flap. And if you look at Ziad Bakin article, the one in 2007, this article is a little bit older. I'm familiar with the gentleman. I don't think he practiced the rectangular flap the way that we practice it. In a way, he is the dean of dentistry in Jordan, and he's actually a nice person, and I know him personally. But I've actually seen him work, and I think his description of the triangular flap is not the same way we describe it. As a matter of fact, if you look in the Cochrane study, it says that Cochrane study is done by the usual suspects, so just Spicetto and Paul Coulthard. And what does it say? It says that there is no difference, but they've noticed that there is actually less swelling, right, with rectangular flap. Uh, and that actually is going coinciding very well with the way that Dr. Qadi, who me and you know personally as well, who just mentioned that there is less pain, less swelling with one suture flap. And one suture flap cannot be compared unless if you do a rectangular flap, because then you will catch up the top of the flap and you will cover it. You will go off from buccal to lingual. And, some of the people who have worked closely with me know exactly what I mean. They just do one suture and that's it. And that has proven that it has less swelling. It's probably the same with the final out when it comes up to the final outcome. And as Dr. Kadi said, even though that there is a difference, but it's probably clinically insignificant. At the end of the day, what you have mentioned is something good, is that the flap that you practice the most will always work very well with you, because as we may know as clinicians, is that the more that you do of certain thing, you happen to master it. And yes, there's some surgical principles, and if those surgical principles have been respected in all of the flap designs, then I think the outcome is just going to be the same. So this is the message that I want you to take, with you, is that protect your anatomical structures that you have. Make sure when you make your incision, to make your incision continuous, clean cut to the bone. if you are, the purpose of your incision is to obtain up a full thickness flap, full periosteal thickness flap. And once you raise it, try to raise it. Try not to tear the periosteum. Try to protect your flap with the periosteal, with the Minnesota retractor or any other type of retractor that is available. Don't get your rotary instruments if you're using rotary instruments like surgical hand pieces to do that. Talking about surgical hand pieces, please, please, nobody uses regular hand pieces whenever they remove bone. You know, even I'll be extremely cautious whenever I do a subgingival buccal filling. You know, one of my colleagues have told me in New York, in the Mount Sinai, not in Canada, in New York, Mount Sinai, there's been actually a very, very bad case of air emphysema. It just occurred after extraction of wisdom teeth where the general dentist used up a regular handpiece, not a surgical handpiece. So please be extra cautious with these things. These are the type of actions that it's undefendable, meaning is that me or nobody else can defend you if it happens. And the answer to the question, Dr. Hassan, what if the handpiece was not working? What if I don't handpiece? Well, guess what? Don't do the procedure. Just give antibiotics or if it's needed or painkillers and just bring the patient on another day. So that's not an excuse that I didn't have it to do it wrongly. So please don't use any hand pieces.